Hello guys, chapter 15 we are working on today, and that is working with children and adolescents. So, objectives: understand the childhood self, learn about the importance of play, discuss respectful interactions in children as active participants, and what is actually adolescence. One of the most important things to realize with children and adolescents is that we have to recognize them. This is that kind of stage when they're starting to move from infant to childhood, and they start to see themselves as their own person. And that's that recognize that one has a self separate than others, that I'm my own person, I can make my own decisions, and that I am my own person, but I still need to have these other people so that way I can survive. Activity and energy are focused on being different. However, learning how to be accepted by others, having some say in a relationship, is just as important. And that's that recognizing that they are able to have a say in what they do. And they like that. They like to be able to decide what they want to eat, what they want to wear, and how they want to move forward. They also, just because they are children, they still need respect. Usually when a child is ill, they typically regress to some point. I know that when a child has surgery, when they are infants or really young children, they typically regress about 6 months in progression. Unfortunately, we won't be doing a screen talk with my friend Jessie Ann, whose son has Apert syndrome, but he is about a year behind Reed developmentally because of all the surgeries that he's had. And really, he's only 5 days younger. So the more, when kids become ill, they regress in their progression, and we need to understand that. Importance of play. Now, we talked about all the play last chapter. It doesn't matter where they are or what they're doing. It is vital that these children have the time to play and have the time to be a kid. 2 examples we've talked about is associative play and cooperative play. Sorry about that. I paused there because I realized that this slide is wrong. It's not even correct. So let's go over the types of play again real quick before we move forward. Symbolic play, that's when you become a doctor. Onlooker play, observes but doesn't participate. Parallel play, that's side by side. Associative play is a shared activity but little organization. Constructive play is building things, and cooperative is rules are followed. So soccer, basketball. So cross out that associative play. Not sure what I was thinking there, and I apologize. I paused because I'm like, that's definitely not right. So again, the time as a child, that play is sort of like their occupation right now. There are some school issues. Disability is sort of an umbrella term for all of the impairments or any activity limitations. There is a new federal law, the IDEA, Individuals with Disabilities Education Act, and that is a federal law that governs the provision of special education services in the least restrictive environment appropriate to their needs. So they take a look at what exactly does the children need in this form, and we are going to try to find it in the least restrictive environment so they can stay the same as every other child without making them so different. Some concerns on that. Well, there's bullying. We all know that kids can be relentless and nasty and rude. I think that there has been some improvement with the bullying in schools. And kind of standing up for what's right with our kids, but it's not going to stop. But that can be a concern. Not receiving the same education, that they're not getting exactly the same as every other kid. And then a time factor for teachers. It can be difficult and straining for them on top of what they're already doing. Kids also don't want to be out of the action. So they want to be in with the rest of the children in the same classroom, and they don't want to be excluded from what's happening. So that can also be an issue. So if we talk about respectful interactions with the family bridge here, the 7 to 12-year-olds will start to develop their own sense of values. We've already talked about values before. So when you're thinking about that and thinking about what your values actually are, they are not going to be the same as a 7-year-old. And that's okay. They are independent from their own thinking, and they're going to be doing and progressing their own values and creating their own values that they feel are important to them. There are overprotective parents, which we like to call helicopter moms. They are just kind of sort of hovering over everything that's happening and what's going on. We want to be in, when I sit here and list respect as an option too, I want you to know that that's not only respect for the child, that's also respect for the family and the parents. Those parents know their kid. They have been with their kid. They have raised their kid. So making sure that you are taking the time to listen to their parents. I have here, according to Lawler and Mattingly, collaboration is much more than being nice. It involves complex, interpretive skills in which a practitioner must understand the meanings of illness or disability in a person and family's life and the feelings that accompany these experiences. So take a minute to think about what that actually means. Collaborating with a family or with a patient it's not just about what you know and how you can give that knowledge to your patient. It's the whole picture. It's the whole scheme. It's the patient, family, diagnosis, socioeconomic status, their life at home, friends. It's everything that you can bring into the picture and collaborating with all of those aspects, but also the feelings that come with these experiences. You may not understand how a parent feels with a child with a craniofacial disorder because you don't have a child with a craniofacial disorder. And you can think that they should feel this certain way, but everyone is going to be different in how they're feeling, and you have to be respectful of that. I do like to talk about children as active participants because like any other patient, if you aren't getting your patient to participate, it will be not as effective as if they did. So the legal age of consent we know is 18. But there is a thing called assent, which honors respect for the persons and should be sought from the age of 7 upwards. It ensures that they can communicate a choice and have a say in what happens. It is okay to allow your child, or I should not your child, I guess the patient you could say, from the age 7 or upwards to have sort of a say in what they're doing. And a lot of the time the children don't really say it, but they express it in how they're acting or moving. Are they being open and upfront and talking, or are they being a little bit reserved and their heads are down, their eyes are averted? We have to make sure that we're watching the whole body language and their actions of what they're doing. Children are also very connected in how they respond to their parents and other people around them. If the parents are showing some anxiety or opposition or denial, the children are going to feel that without even having to say anything. For you guys, making a good healthcare professional to a child, good communication with the patient, coming down to their level, talking in terms that a child will understand. Professional competence. Safety and appearance. If you are frazzled with your hair unshoveled, that's not going to be good. And knowing that you have the safety of that child under control. Any virtues, and then making it fun. Trying to help ease some of that anxiety or uncertainty for your child. It's important. So how much information should you share? And this is on page 289 of your book, and it sort of goes into a little bit more description. So when you have some time, take some time to run over to that page and kind of look up what exactly it's talking about. I'm not going to read it on the slide. That's going to take too much time. You guys are adults. You can do it. Make your position clear to the patient, to yourself and to the parents. Explore the resources available in the healthcare setting. So you aren't the only resource that family or patient needs. There's social workers, ethics committees. There's other options that you could go to and other resources that you might know more than the family. And it's important that you're advocating for them. Present information in a way that the child can understand. So that opens up the door for the child to allow for questions and communication and really be a sense of what's happening. And that, again, like we said earlier, that child likes to be a part of what's going on. They want a decision. And if you can open that door for them, that's going to be imperative. And implement any strategies to lower the family stress. 2 major tasks to lower stress is 1, provide information, either daily phone call, meetings, emails, and 2, involving the family in the care, not just in the clinic, but at home. Those 2 major tasks will help lower the family stress and will help implement some easier tasks for you and will ultimately just help the child get better. The adolescent literally means to grow into maturity or adulthood. So we're starting to move forward into that puberty stage. The adult bodies are starting to grow and they are looking at how they are perceived and treated by others. So there are 2 typical stages. There's early and then there's late stage adolescence. The early lasts about 2 years. This is usually between 10 and 19 years of age. You have your growth spurts, you're starting to mature, your reproductive functions are starting to come. You're starting to figure out what's fitting in and finding your own self. Which kind of can be for not only how your body looks, but are you fitting in, changing roles? Are you an athlete? Are you in band? Are you a cheerleader? Do you like golf? You're sort of finding who you are at this point. The book talks about adolescent turmoil, but in a dramatic turn of events, some say it's not as bad as what we previously actually thought it was, which is sort of interesting. In late stage adolescence, they start talking about some children have different things to deal with depending on where they live. So if we think about in developing countries or developed countries, in some developing countries, they'll have to contend with poverty, starvation, infectious diseases. But in developed countries like our own, we have to contend with obesity, sedentary lifestyles, violence, and eating disorders, which is, it's interesting how different, depending on where you live, how your adolescence can look. The late adolescence, which is about 12 to 17 years old, you start to decrease your time with your family. You're starting to introduce some new environments. So we're starting to do work settings, peer relationships, high schools. You're looking at romantic stuff sort of happening with boyfriends and girlfriends. You start to question their old values without losing who you've already created who you are. Some negatives in adolescence, you have the substance abuse, violence, and suicidal behaviors start to pop their ugly head. Some positives, though, is that you are getting some more social acceptance and your family influence and from friends can make a huge difference in how your behavior is. The more family time, the better. So having respect and autonomy, there is a mature minor doctrine, which is a statutory, regulatory, or common law policy accepting that an emaciated minor patient may possess the maturity to choose or reject a particular healthcare treatment. They start to develop and emerge as their own decision maker, and you can try to assess maturity, but by how they cope with their injury and illness. It has to be, a doctor has to say that they are mature enough to do that, and this allows the minor to speak for themselves. Why? If your parent is sitting right next to you at the age of 16 and your doctor asks you a question, you may not answer it truthfully because your parent is sitting right next to you. I remember when my doctor asked my mom to leave. And I was sort of nervous, but I knew why once they left, because they were asking me questions about sexual activity or drugs or alcohol. And they know that I wouldn't answer that question honestly if I was sitting right next to my parents. This is independent of any parental judgment, so they are outside of the room. And finally, just to sort of wrap up, bringing everything together here, adolescents like to argue about the rules, really. And even though they are arguing, they're still going to accept them. They're just going to push their buttons and see how far they can push it. All children need their limits, which is why why they should have rules in place, because it helps set those boundaries. Peer group activities are essential for identity formation. Injury and illnesses sort of can put a kink in that, but allowing your patient to find their own identity is ideal. If you guys have any questions, please don't hesitate to ask or email me. I'm happy to answer. Thanks. Have a good day.